Next, we move on to a very interesting and an important disease, von Willebrand disease. It is the most common inherited bleeding disorder, not hemophilias. So, what exactly is the von Willebrand factor? So, this von Willebrand factor, it circulates as polymers, as you can see, circulates as polymers. So, they are stored in platelet Weibel pellet bodies. They are also stored in the endothelium. So, subendothelial von Willebrand factors. So, these subendothelial von Willebrand factors, they have receptors for platelets. So, the clinical features of von Willebrand disease will present as mucosal bleeding. It is mostly mucosal bleeding, not joint bleeding like hemophilias. So, mucosal bleeding can be anywhere: epistaxis, easy bruising, menorrhagia in women, surgical bleeding are also common. We have many different types of von Willebrand disease. Type 1 is the most common. Type 1 and type 3 are quantitative deficiencies, that is, von Willebrand factor levels are less. In type 1 it is partial, at least some von Willebrand factor exists, whereas in type 3 complete deficiency of von Willebrand factor. This type 3 presents to us with joint bleeding. I have already told you that von Willebrand factor presents as mucosal bleeding. But what happens in type 3? So, the von Willebrand factor is completely absent. As you can see, the circulating von Willebrand factor circulates along with factor 8. It transports factor 8. So, it increases the lifespan of factor 8. But since in type 3 of von Willebrand disease, the von Willebrand factor is completely absent, factor 8 gets degraded, so it presents just like hemophilia with joint bleeds. Coming to the next category, type 2. Type 2 is qualitative deficiency. So, when we take the amount of von Willebrand factors quantitatively, it is normal, but they do not work properly. So, why don't they function properly? Again, we have 4 different categories with minute changes in their function. In type 2A, high and intermediate molecular weight polymers will be absent. So, when the multimers are absent, then the von Willebrand factor do not function well. In type 2B is basically a gain of function mutation. So, gain of function mutation, what happens? Instead of binding with the platelets normally, the von Willebrand factors bind with platelets with an increased affinity. So, such increased affinity is there in type 2B. Type 2M is there is decreased platelet dependent function. They do not bind with the platelets, some disorder associated with GP1B receptor, but the multimers are normal. In type 2N, the decreased affinity is with factor 8. So, once again we will go through the classification. So, quantitative deficiency, von Willebrand disease, type 1 and type 3, the von Willebrand factor levels are less. Type 1 it is partial, type 3 complete deficiency. Qualitative deficiency is seen in type 2. Among type 2 we have type 2A, B, M and N. In 2A, formation of multimers, high and intermediate molecular weight VWF multimers are absent. Type 2B is a gain of function mutation. Von Willebrand factors have an increased affinity for platelet through their GP1B receptor. Type 2M, platelet dependent interaction is less. Type 2N, decreased affinity for factor 8. So, von Willebrand factor antigen levels are measured. Less than 30 is diagnostic of von Willebrand disease. There is another type which we have not seen in the previous slide, which is type 1C. There is an increased clearance of von Willebrand factor. Although the quantitatively it is less, it is mainly because of increased clearance. So, desmopressin will not be effective here. And some factors like stress, pregnancy, exercise can increase the von Willebrand factor levels. Hypothyroidism and valproate will decrease the von Willebrand factor levels.